So we have some of them are trainee fellows, some are past fellows, and some are senior pediatric nephrologists who have assembled.
So big group.
It's not a very big group, but it's an active group. We meet every Thursday.
Right.
And so it's a pleasure to have you, and we couldn't have anybody better than you for nuclear medicine.
Thank you.
And I know you have a special interest in nephrology, because I remember you telling me that when you were much younger and at Tata Hospital, you had done a project with Dr. Vidyacharya.
Yes.
Using sulfur colloid for detecting early rejection.
Correct.
So that was very interesting for me. And also I remember that many times you kind of applied your clinical mind to find a solution to what we were seeing with the clinical history. So it's always very nice to have a technical savvy person who also has a clinical interest.
Thank you.
And I will invite Dr. Jyoti Sharma to just formally introduce you to the audience.
Thank you.
Yeah.
A big welcome to Dr. Krishna. Thank you very much, Dr. Krishna, for agreeing to participate and to give us,
on the slideshow,
to explain, to give us this talk. And it's a great honor for me to be introducing you to the students today. Dr. Krishna has many years of experience as Chief Nuclear Medicine Specialist at PD Hinduja National Hospital and MRC Mumbai. He has been the Honorary Professor of Nuclear Medicine at B.Y.L. Nair Hospital since 1998 and Professor and Head of Department of Nuclear Medicine and PET Imaging at Bombay Hospital Institute of Medical Sciences at Mumbai. He is currently the Director of Nuclear Medicine and PET Imaging at Lilavati Hospital and Endocrine Cancer Specialist at SLR Hospital, Mumbai. He has had some major achievements in not only setting up of new techniques like setting up of the radio immunoscanning in colon cancer and the epilepsy scan for children, the first PET scan in the country in 2003. But he has also had some important assignments in his lifetime, which include being the member of the advisory panel for setting up of the National Cancer Institute for Government of India. He has been senior teaching faculty of the International Atomic Energy Agency in Vienna. Among his important teaching activities, he has constituted the Indo-European Education Forum in 2010 and conducted the first Indo-European postgraduate teaching course in 2010 and second course in 2011. He has been a teacher and examiner for the DRM and DNB courses in nuclear medicine for over many years and guided many student theses over the many years. He has, to his credit, numerous publications in national and international journals and has been has been the recipient of many awards and orations, including the prestigious Dr. S.K. Sharma Oration at Kolkata in 2010. So I hand over the mic to you, Dr. Krishna, and thank you very much once again for being with us.
Thank you very much for your kind words. It's indeed nice to talk to the youngsters and put into them the thoughts of new approaches to various clinical scenarios. Today, what I will do is I will take you through a little of the basic concepts of using the isotopes in the nephrology practice. Am I audible?
Yes, you're audible.
Yeah, thank you. Actually, in the field of nuclear medicine, the major applications that came early in the phase of its growth was the nephrology and urology, along with thyroidology. From that, we have moved on a lot, but the practice of nephrology, both at the pediatric and at the adult level, has almost remained the same, barring few new inventions. In a broad sense of term, the indications for isotope studies in nephrology are to assess the perfusion and function of the kidneys, to evaluate obstructive uropathies, in adults, renovascular hypertension, infection predominantly in the pediatric setting. Very rarely we do that in the adult. Pre-surgical quantitation when a nephrectomy is being considered, especially in the adult group where they are planning for a upper nephrectomy in tumors. In renal transplant, we did play a major role almost for 2 decades, but with the advent of color Doppler, our role is much, much limited. Congenital anomalies continue to be one of the major indications for static renal scans. Just to conceptualize the basics of on which we depend our studies, the renal function, the blood flow, the filtration fraction, the tubular secretion, the tubular reabsorption, and finally the endocrine functions. Each one of these can be assessed using different isotopes targeted towards the renal area. So normally we know blood flow is 20% of the cardiac output, filtration fraction is 20% of the renal plasma flow, or the glomerular filtration rate, and the tubular secretion. These can be quantified on an isotope study, and the relevance is significant, especially in the transplant scenario. Tubular reabsorption and endocrine functions, we do occasionally get into this scenario for using isotope studies. Now, coming to the major tracers that are being used in the nephrology is, we remember 2 great professors. Professor Blaufox was the man who enunciated the tubular areas, and Professor George Taplin was the man who enunciated the glomerular filtration rate concept and using the isotope studies. Both are from the Mass Institute of Mass General Hospital. So DTPA, MAG3, OIH, that is ortho-iodohippuric acid, then glucoheptonic acid, and dimercaptosuccinic acid. Now the issue is, when I started the practice way back, it was only the ortho-iodohippuran labeled to radioiodine which was available. But for 10.
A second, can please all the attendees please mute your audio so that there's no disturbance?
Okay. Right. So ortho-iodohippurate, radioiodine, was the first isotope applied for renal studies at the Mass General Hospital. When I was at the RMC at the Tata Hospital, this was the isotope which we used in the 1978 to 85. This particular problem of this was that the radiation dose to the child was quite high, and the images were not coming on the gamma camera, and it was more of a tubular secreting agent rather than glomerular function. Because of certain deficiencies, this isotope went backwards, and the DTPA came as the frontline isotope in the evaluation of nephrological problems. The MAG3 is a pure cortical agent which we use predominantly in looking at the cortical scars or cortical issues. We also use DMSA also as a cortical tissue, and MAG3 in India has got a different compound because MAG3 is very expensive. It is predominantly used in UK for tubular secretion studies. We use here EC, ethylene cysteine, and that is the compound similar to MAG3. It is not inferior, it gives the same result as the MAG3, and we use that routinely here in India. The GHA, glucoheptonic acid, came up in the 80s and 90s for studying the renal cortex, but today it is not used. It has gone out of the practice. So the youngsters should remember DTPA, MAG3, EC, and DMSA. Now, these four compounds are labeled to an isotope called technetium, which does not give significant radiation in the pediatric scenario, because this isotope does not have a beta ray. It has only a gamma ray. All those isotopes which have beta ray with them, they give radiation. So hence technetium 99M isotope hooked to DTPA, DMSA, MAG3 and EC do not produce significant radiation, so can be repeated as frequently as 6 months if needed in a pediatric setting. The DTPA is 20% extract by the kidney, and it is predominantly telling us about the glomerular filtration rate. This isotope, once it is filtered by the glomerulus, goes through unabsorbed and unchanged. Hence, it is ideal tracer for assessing the glomerular function. Once the serum creatinine level goes above 2 or 2.5, the images of DTPA are not very good, because the extraction of the DTPA is only 20%. And in a high creat patient, the extraction would be further reduced. So the image quality is not very ideal. So in all patients above creat of 2.2 to 2.5, we use either EC or MAG3, whichever is available, because the extraction fraction by the kidney is around 40 to 50%. And these two compounds, EC and MAG3, give us effective renal plasma flow. So we have different isotopes for different quantitation of the renal function. Whereas the oldest isotope had 100% extraction by kidney, but had a high radiation dose. So today, DTP and MAG3 are used along with EC in an Indian context. If you look at the radiation dose that a pediatric kidney would get, which is mentioned here, you will see that the bladder becomes a target, because most of the isotope that is excreted comes and stays in the bladder, and hence bladder, it becomes a critical organ for us. So that is why we ask them to avoid as early as possible the moment study is over. Whereas the DTPA radiation dose MAG3 and are not very high. The DMSA is on the higher side because this compound fixes to the sulfhydryl groups in the renal cortex. It does not come out of the renal cortex. So having stayed in the renal cortex, it keeps giving radiation, which is minimal, but still in a pediatric setting, one would be worried to repeat such scans very frequently. And the isotope in a DMSA dies by itself after 6 hours. Till that time, the cortex is getting radiation. So from this point of view, if I have to make one important message to you, is DTP and MAG3 become excellent isotopes without much worry. And DMSA, of course, with the selected indication it has, so we do not much worry, because in that indication, the information yield is much better, much more compared to the minimal radiation dose. So what isotope to use where is a question which often comes. So if your question is perfusion alone, let us say post-renal transplant, you suddenly find that the kidney is shut. You are looking for a probable graft stenosis. You have done a color Doppler. You are equivocal. In that setting, you can use any one of these three agents, MAG, DTPA, or of this, and take 2 minutes picture only, and you will establish the perfusion of the kidney. No perfusion to the kidney means the graft artery is blocked. So like that, depending upon the clinical question that you have put to us, the isotopes are chosen. When you want morphology or anatomical abnormalities of the kidney, we need an agent which stays within the kidney. So there we use DMSA scans for morphology. Obstruction, it will be DTPA, MAG3 or EC scans. In children, it is preferably we go to either EC or MAG3 as a European recommendation. As far as I am concerned, I think DTPA also works well and equal images come so far as the creat is within normal limits. For the relative function of each kidney, you can use any of these isotopes. For GFR quantitation, we need the DTPA, or we in vitro studies, we do chromium 51 EDTA, which I used to do in the earlier days along with the BARC group. And now it is not available because the DTPA GFR was well correlating with the EDTA values in the study that we did in the early 75 and 78. So now this in vitro value is not available in this country, but abroad, I think in all pediatric scenario, this in vitro value is still continued. ERPF quantitation is done using the EC scan or the MAG3 or the orthoiodohypurate scans. After knowing this funda basic, let us see what exactly is the procedure. Patient must be well hydrated. Here, give 5 to 10 ml per kg water in 2 to 4 cups or 30 to 60 minutes pre-injection. You can measure, if abroad in Europe they do that, specific gravity. You void before the injection of the isotope and void after the end of the study. The patient is in a supine position. In abroad, in some centers, they have a little sitting posture done, but there the procedure is difficult to perform unless it is in a very cooperating 7-year boy or 8-year like that. We do not inject straight by straight strip. We secure an IV line. Initially, we obtain an angiogram, what is called renal blood flow study. These images are taken every 2 to 3 seconds for 1 minute. And after that, the dynamic images at 15 to 30 seconds per frame, you take up to 20 minutes or 30 minutes. So this would be the format of the procedure. We obtain a 30 to 60 second image over the injection site to know whether any isotope came out while it was being administered. Because if it had come out, the quantitative estimation like GFR, etc., would get affected. So we do not report the clearance if there is an infiltration more than 0.5% of the dose at the injected site. Because this, whatever has come out in the tissue, will slowly start coming into circulation and in the kidney, and the clearance will get affected. You get an impression as though the clearance is delayed. Obtain a post-void supine image of kidney at the end of the study. Post-void image is very critical for us. And now we also take a delayed 30 minutes and 1 hour study also to see what is the impact over a period of time. The International Committee recommendations for the basic renogram: tracer MAG3 DTPA, dose 2 to 5 millicurie adult, minimum 0.5 millicurie for the pediatrics. Patient position is supine. It includes the bladder and the heart. Heart it includes because if you want to know whether you have injected nicely without any extravasation, the heart curve will tell us how the isotope went into the heart, how rapidly it was taken by the kidney, and that helps us in some way to ensure that the study was properly done. And we also, as I said, we image over the injection site. This was a consensus recommendation done, especially in the pediatric setting. Now, the first image. This is called renal angiogram or blood flow study. You can see here the aorta, and these are the two kidneys. And then in the third image, you are seeing both kidneys with excellent aorta. So what are the information I get from this particular picture? Number one, aorta is fine and the transit through the aorta is excellent. Number two, aortorenal time is perfectly normal on both the sides, and which you can see here, the uptake in both kidneys is fine. Now in this 1 minute image, you can make a diagnosis of a renal artery stenosis. If there is one kidney not seen, at the time when the contralateral kidney is seen, that means that side which is not seen has a probable renal artery stenosis. So what is the time? We call it as aortorenal transit time, which is in seconds, 2 to 3 seconds. And this is very important for us. And number two, during this study, we also occasionally, I have picked up an abnormal area above the upper pole of the kidney shining as black as the aorta, classically telling us there is a vascular tumor above the kidney, and most likely in the context of a hypertension, that will be a pheochromocytoma. And number three, aneurysms of the aorta can also be diagnosed on this simple 1 minute study. And number three, in a transplant setting, the flow into the transplant can be decided within this 30 seconds image. So the angiogram, which is done as the first part of the study, is an excellent study. In fact, there are 8 extrarenal abnormalities picked up on a 1 minute study, which in a pediatric setting is not that important, but very important in the adult study. Secondly, if you see here, you see the kidneys and you see only the spleen, and liver comes up later, that is classical circulation. If I see the liver activity in the early phase, in the first or second picture, it almost certainly says there is a vascular tumor in the liver. It's an important observation published many years ago, what we call lateralization of the tumor. So during this study, we pick up varied patterns of pathologies apart from the kidney information. After taking the dynamic image, we have every 1 minute sequential images, which you can see here. The first image or the second image is the image where you must look for cortical function. After that, the tracer has moved to the excretory system. So please remember, cortical function is estimated on the first or the second sequential images taken up to 20 minutes. And here you can see the left kidney, and this is a posterior view. Left kidney and the right kidney you can see, and we can put an area around that and generate a quantification. And in the third and fourth, you start seeing the calyceal system and the renal pelvis activity. As it moves on, then you can see that in the succeeding images, you see the arrival into the calyceal system, then into the ureter and into the bladder. And this is what we call as visual image interpretation of a renal study in any given stitching. So visual image has to be kept in mind before making a final conclusion. Now here, when the excretion is taking place normally, this is called a normal study. Then the computer in the second image puts an area of interest like this around the kidney. This is the most critical part actually. If I give some function, somebody else gets different function, it is because this area around the kidney has not been properly put. And secondly, there is another area which we put, it is called background area. There is an isotope floating anterior and posterior to the kidney soft tissue. We don't want to calculate that into our quantification data. We want to eliminate that soft tissue component. So we put a background area like this, which will equate to that soft tissue activity, and the computer minus this area activity and then gives us what is called function of the individual kidneys. So please remember, cortical function is done on 2 or 3 minute image only. Now, what is how do we calculate contribution of each kidney to the total function? Percentage of the left kidney is equal to the net radioactivity in the left kidney divided by the left plus the right into 100%. So that is the way the software calculates it. Normally, it's supposed to be 50 and 50, but in reality, it doesn't happen so. So we take current recommendation is 56 to 44, right to left. If you get such a function, you can still take it as normal. But while looking at this function, we also see the size of the kidney. That is very critical. And borderline reduction, 57, 43, 49, 59, 41. And abnormal is 60, more than 60 and 40, right and left. So this is the current protocol that is followed by most of the centers while trying to tell you that X kidney is under functioning or having comparatively less function. From the images that we got, we will be generating a various different quantitative data. That is time to peak. After I injected, what time it took for the kidney to show peak activity, and that is called time to peak, very critical in renal artery stenosis, very critical during the follow-up after pyeloplasty or in obstructive uropathy. Normal time is 3 to 5 minutes. Then residual cortical activity at 20 or 30 minutes, ratio of the radioactivity at 20 minutes picture or 30 minutes, peak counts. Now this is very important. This will tell us how is the function, because ideally at 20 minutes there should be hardly any activity in the kidney. So residual cortical activity represents the functional status of the kidney. And residual urine volume, we do that pre and post void. Post void counts into voided volume divided by pre void counts and post void counts. Now these parameters are also given in the same one injection. So in one injection of the isotope, all these parameters are being taken into. So this is an image where the GFR is very low, creatinine is 2. And we have done a DTPA scan. What you see here, very interestingly, I have just purposely shown how important it is to look to the clinical parameters before you fashion your study, that in this patient, ideally should have been the EC or the MAG3 injected. Because the creatinine is high and GFR is low, you can see a lot of soft tissue all through the study. Kidneys are seen in a very poor fashion. The borders of kidneys are not well made out. There is a lot of activity hanging around in the liver and the spleen because kidney is not extracting. So this means, this is just a picture to show that when you refer us, if you yourself can say the patient creatinine is high, we would like to have an EC scan. But now anyway, as a rule, following the European model, we have made EC scan as mandatory in all the pediatric setting. But once such a study is done, all the data that I will give you will not be accurate. There'll be a lot of fallacies because there's a large amount of soft tissue circulating activities. Now here is a beautiful case. I mean, it's an adult. The aorta, that's the iliac arteries, the left kidney beautifully seen, the right kidney is not seen. And right kidney activity slowly starts coming up by the time when the left kidney is excreting. So absence of visualization of the kidney during the arterial angiogram phase with slow pickup later is a classical renal artery stenosis picture. And in fact, the color Doppler today has almost replaced us. There is no issue about that. But I'm just for a PG students, renal artery stenosis can be diagnosed in 1 minute study if you have that clinical suspicion. Now this is what you see here, the same patient. There's hardly any uptake and the small left kidney can be seen here. Very small left kidney, and this was a hypertensive patient. And what you see is the left kidney is almost non-functioning. The role of isotope in this scenario, as far as adult is concerned, I'm just showing this for the purpose, is to determine whether this kidney should be removed or should be auto-transplanted or there should be an angioplasty done. Since this setting is not common in the pediatric setting, I won't like to go into more details of this. If you have any, you want it, then you can discuss in the end. Now coming to the static images which you saw is graphically represented by the computer, and that is called a renogram phase, or you can call renographic phases. So there are 3 phases of a renogram: vascular phase, parenchymal phase, and washout phase. So what is a renogram? Renogram is a graphic representation of the arrival of the isotope into the kidney, its movement through the kidney, and its exit through the excretory apparatus. The whole thing is called a renogram. Renogram is very critical because we can tell you pre and post surgery extent in terms of percentage, how much improvement, how is the pattern. So renogram is very, very essential component of the interpretation of the data. In the renogram, we also have this particular point at the top is called the peak time. So from here to here is the peaking of the isotope, and from there downwards here is the excretion. So this peak time, what you see here, is called a slope of the renogram curve. So far as the slope of the renogram curve is sharp, the kidney function is excellent. If the slope of this curve becomes blunted or becomes little curvilinear, that means the kidney has lost the function. So slope of the second renogram curve is the most critical component as far as the functional integrity is concerned. And from peak to down is the excretory status. And this will tell us the pattern of obstruction is made up on this curve. How down fast? Normally, it has this sharp fall, and within 12 minutes, you'll see 50%. So these are 2 curves which we use in interpretation in the obstructive uropathy also. Now coming to the first indication now is the hydronephrosis. There we have diuretic Lasix renogram or Lasix renal scan. Concept is obstruction to urine outflow leads to obstructive uropathy, hydronephrosis, hydroureter, and that may in the end lead to obstructive nephropathy, loss of renal function. So hydronephrosis, tracer pooling in the dilated renal pelvis. Lasix induces increased urine flow If the system is obstructed, post-LASIK, it will not wash out. If it is only dilated and not obstructed or non-obstructed dilatation, it will wash out after the LASIKs. And we can quantitate the washout post-LASIKs, on which are dependent various diagnoses. This is a very important concept, diuretic renogram. So we use this for functional significance of hydronephrosis, determine need for surgery, obstructive hydronephrosis, needing a surgical treatment, and non-obstructive, a medical or conservative approach. And then we use the study for monitoring the effect of whatever therapy has been given by the clinician. The requirements for doing a diuretic study is you need an isotope which is rapidly going into the kidney and getting rapidly clear, and that is a DTPA. The patient should be well hydrated. If he is dehydrated, the entire study will be fallacious. That is why we take care in the department about hydration in the department itself. And the patient should have a good renal function. If the creat is quite high or if the parenchymal function is not good, then the LASIK renogram will not be of any use because hardly the tracer would move to the excretory apparatus. So in a poorly renal function patient, role of diuretic renography is questionable. How do we pre-hydrate the patient in the department? For the pediatric group, 10 to 15 ml per kg of normal saline, void before the injection. We give this 1 hour before the study or sometimes during the procedure. In Europe, they continue during the procedure. And there is a concept which Americans follow. All pediatric patients with this sort of a clinical problem should have a bladder catheterization for doing an diuretic renal scan. In India, we have been not following this. I will tell you why it is so. Tracer is either MAG3 or DTPA. Acquisition same, which we already learned. There is no change in the acquisition parameters. The LASIX is given 40 milligram in adult or 1 milligram per kg in a child intravenous. Now this LASIX can be, now ideally should be given at the end of 20 minutes because a normal renal study is 20 minutes duration. You want to study the renal physiology unaltered up to 20 minutes, and after that you intervene and alter the physiology and then again reacquire. So normally it is injected at the end of 20 minutes. In some patients, we inject 15 minutes before the study starts. This is when you have all done your ultrasound, IVPs or whatever study and a very severe obstruction is suspected. There, instead of having post to 20 minutes, only 10 minutes LASIX action, we want to have a long time LASIX action. So we give 15 minutes before the procedure so that LASIX can act over throughout the 45 minutes of the study and the obstructive component can be conclusively commented upon. So this is, we do it abroad, they first to do conventional and next day call and do an F-15 procedure. In India, because of the cost of the two procedures and to the patient, we are doing in all obstructive uropathy either F plus or F-15. The recommendation for the pediatric is inject the LASIX along with the isotope. It is called F+0 diuretic scan, which is now followed in many centers. Acquisition goes on for 30 minutes post-LASIX and assess adequacy of diuresis. That is, measure the voided volume. Adults produce more than 2 to 300 ml urine post-LASIX, which is another way of assessing the diuretic response. We do not give LASIX if collecting system is still filling or collecting system is not seen by 60 minutes or the collecting system drains spontaneously or poor ipsilateral function, less than 20%. In this scenario, the Lasix is usually withheld. I'm just showing you one or two examples. You can see here a patient, and what you see here in the pre-Lasix study, the left kidney cortex is thinned out and compared to the right, and the function is very heterogeneous, less here and more here. That is during the function phase, 2 minutes image. As you move on to the calyceal system, what we say here is there are timings which I would like you to remember. Cortico-calyceal time. In this kidney, the cortical calyceal time is normal. It is seen by 4th minute, which is correct time in pediatrics. Whereas in the right kidney, calyxes are not seen, so the cortico-calyceal time is delayed, is prolonged. There itself it tells us that there is a significant back pressure effect. And then calycio-pelvic time. Here it has already come to the pelvis and moved out from here, whereas on the right side, it is hung up in the calyx, slowly coming to the pelvis. So there is a significant delay in the calycio-pelvic timing. These timings are very critical in the pre-op setting because in the post-op setting, we expect majority of these transit time to return back to normal to say a successful pyeloplasty. So transit time should be given value to you in your report saying delayed or normal. So here you see the right kidney is holding at the Puget level while the left is normal, and this would raise a suspicion of both mechanical as well as functional obstruction. And at the end of the previous image, Lasix was given. Now you see the movement of the tracer rapidly moving out of the calyx, out of the renal pelvis, and hardly any activity in the PC system. Now, this is a classical functional Puget obstruction. Now, here, the cortical thinning reduction in the cortical thickness is a matter of worry in terms of whether one should go ahead for surgery or one should conserve. But I think these are the clinical issues which could be discussed later. From a standpoint of renogram study, this would come up within the observable group. And repeat the scan after 6 months or 1 year later. The renogram curve is showing you here the type. This is I think this is a different curve. Yes, you can see a delayed excretion, and computer shows you how delayed it is going on. So post Lasix, this is another example where the right kidney is enlarged, cortex is significantly thinned out, cortico-calyceal transit is considerably prolonged till here. It has not, calycio-pelvic is much delayed. Nothing has come within the renal pelvis even at the end of 20 minutes. This is suggesting a severe obstruction with back pressure effect. And in this patient, even after Lasix, if you see, there's hardly any activity in the renal pelvis. This would be called as an obstructed PUJ with significant back pressure effect. And here we try to calculate the function of the kidney in this image. So while we calculate, we take only the cortex of the kidney and then give you the function of this obstructed kidney. One of the errors we make here is the enlarged kidney fallaciously gives a higher function because of the size itself. So this issue has remained even today and unanswered how to get over this issue, because this kidney may show 45% function, though it is not the true function. So this is one of the errors which continues to be there in the severely obstructed enlarged kidneys. Now you can see the curve, it is flat, and after Lasix, there is no washout at all, what we saw in the image. So what we say here, T half is not seen at all. Now, this is another patient where you see a 3-week-old baby with a large kidney, and this is showing very poor uptake compared to the contralateral. There's hardly any tracer into the PUJ, and post Lasix, there is some movement. Now here, again a fallacy is there with as far as our study. This may be called as a mechanical obstruction or an obstructed system. But in children less than 1 year, where the kidney is immature, it is impossible to comment upon the Lasix study because response to Lasix in the immature kidney could vary significantly. So many a times I write that since the function is normal and there has been a movement of the tracer to the renal pelvis, and the delayed 1 hour image, if we take this activity would have gone down further, we say that we could observe and redo the study when the child is around 1 year. So immature kidney in producing certain false positives needs to be kept in mind. Normally, I make a comment of this in my reports. And you can see that there's hardly any excretion. So diuretic renography in children less in this group of 3 weeks is a difficult venture. ROI placement, that is region of interest, placing on the renal pelvis, on the renal cortex, on the collecting system. These are all very important technical issues which may produce an error in functional assessment. And also time activity curve generation is done by putting this region of interest around the kidney. And also one should know the 50% activity going down after Lasix from the injection, from the diuretic response. Means diuresis starts actually 3rd or 4th minute after the Lasix. Some people say start taking the T half from that, but I don't find much major problem. It is essential to note when is the 50% activity gone down after Lasix. So what we do is wash out diuretic response, time required for 50% of the tracer to leave the dilated unit, that is time required for activity to fall by 50% of the peak. This 50% is very critical. Supposing it is 30%, what am I going to do? These are called as gray zones. We do not know whether that is obstructed or it is non-obstructed. Now in this gray zone, where it is only 30% washout after Lasix, it is mandatory to do a F-15 Lasix renogram, giving more time for the kidney to wash out. And if you do that, another 40% of those patients who would have been called as obstructed would go into functional PUJ by doing a F-15 renogram. So 30% washout after Lasix calls for a second study, F-15. But in a pediatric setting now, as I said, we are doing right in the 0 level itself. And because the child cannot be called again and again, so we have compromised and made a F+0 Lasix in this setting for all children. Now this is the curve. This is this is the 100% activity in the renal pelvis when the Lasix is given. And after Lasix, 50% T half is reached by the 6th or 7th minute. This up to here 10 minutes. So by 7th minute you have got, it's an excellent Lasix response suggesting functional delay. So what are the variables which may influence T half? Because T half is a determinant of obstructed versus non-obstructed. So tracer itself, depending upon what tracer you are using, like MAG3, EC, DTPA, and the creatinine, state of hydration, dehydrated patient, you will get a wrong T half values. Volume of the dilated pelvis, that if the volume is very high, probably your T half may not be achieved because more and more retention occurs you may have to take their delayed images. Bladder catheterization does help in selected cases. I will show you an example. Dose of Lasix. If you give suboptimal dose of Lasix, then the response will vary. Obviously, T-half varies. If the renal function is poor and the kidney is not able to respond to Lasix, your results are not going to be reliable. Region of interest drawing by us is critical. Pelvis should be beautifully separately drawn and kidney should be separately drawn, and separate curve should be obtained for pelvis and kidney. And T-half calculation should be from the injection versus response, and use the computer for what we call as curve fitting. So normally it is less than 10 minutes, T-half. Obstructed is more than 20 minutes, and indeterminate is 10 to 20 minutes. It is in this indeterminate group we have to do F-15 Lasix renogram. Best to obtain, we have to obtain our own normals because all this hydration and all these things have to be taken care. Interpretation, not to interpret only one curve. Interpret the whole study, cortex, calyx, pelvis, caliceo-pelvic transit times, and T-half, and visual images, size of the kidney, washout curve shape, slope of the curve, and finally T-half. All of this should come as a single comment in the end in interpreting the data. Pitfalls in the diuretic: false positive for obstruction, distended bladder. Distended bladder will give you a false positive because it's acting as a pressure, not allowing it to come down. Gross hydronephrosis, poorly functioning or immature kidney, dehydration. False negative, very low grade obstruction or poorly functioning immature kidney. When we report, we take all that into consideration. I'll just show you one of my American friends. He used to tell me, why don't you catheterize all? If you look at this here, a very nice kidney. There is some PUJ here on the left kidney. The right is clearing, but the left is not clearing. Bladder is full, and this continues to persist. But on the same patient, when you catheterize, you see the left one, which was holding up previously, now completely clears. So with catheterization, some of these false positives which will come might be eliminated, but catheterization is not a simple, easy procedure. It has its own attendant issue. So what we do here is we go ahead and take delayed 30 minutes and 1 hour image. You people might have seen these reports, delayed image washout. If whatever was holding after Lasix like this here, in the 1 hour or 30 minutes image shows complete clearance, that is enough to say it is functional. One need not have a catheterization for this. Or for a moment, if the child is able to walk through for some few minutes and then retake it, that will also help us after voiding. So I have come across in my last 40 years some 7 or 8 scenarios where I had to do a repeat study with a catheterization. Otherwise, majority of the time, we can go ahead with the delayed image. So a question may be asked, what is the relevance of delayed image? It is in this clinical scenario. So if you look at without catheter, that kidney was showing a delayed excretory curve. The T-half is not reaching at all. The T-half should have reached here, but even up to here, the T-half is not. So a false, but after catheter, sharp curve, telling that there is no obstruction. So sometimes you may have to, and the clinician will also have to take a call whether they would like to do a catheterization. F-15 diuretic renogram, furosemide injected at 15th minute, kidney in maximal diuresis under maximal stress, Some equivocals will become clearly positive and some will become clearly negative. Two major publications came in the 87 and 92, and I also have similar experience. So moving on from the obstructive uropathy, the next setting that is in the pediatric scenario is the renal infections. Here, you already have enough data at your level, lot of information you have, but you would like to establish a scar. Is there a scar in the kidney? Sonography appears to be inferior for the demonstration of kidney in terms of sensitivity. It does raise a suspicion, but sensitivity is less. So what we need here is not an isotope which moves out of the kidney afterwards. No, we need an isotope which remains in the cortex of the kidney so that I can take serial cortical images, because we are not interested in the pelvic system, the details of which will be already known. So this indication is in vesiculoureteric reflux, risk factor for pyelonephritis. Not all patients with pyelonephritis have VUR. Pyelonephritis may lead to scarring and end stage. Early diagnosis will help. Clinical and laboratory diagnosis of renal involvement in UTI unreliable in certain percentage. Determine the involvement of the upper tract kidney in acute UTI, acute pyelonephritis, detect cortical scarring, chronic pyelonephritis, and follow up post-treatment. We used DMSA, dimercaptosuccinic acid, which is a compound which fixes to the sulfhydryl groups of the renal cortex and stays fixed to the kidney. We acquired dynamic images followed by 2 hours and 4 hours static images of the kidney, and then we find out the function. We also now do what is called as tomographic kidney scans. What they now say is quantify the scars. The reason for that is the larger the volume of the scar, more probability of the child developing hypertension in the ongoing period. Acute pyelonephritis, single or multiple defects. The defect here is the scarred kidney does not pick up the isotope. So we call it as cold. Renal contour is distorted, very critical finding. Diffuse decreased uptake or diffusely enlarged kidney. Now these 4 factors, if they are there, it goes for acute pyelonephritis. Volume loss, cortical thinning, and defects, chronic pyelonephritis. However, this differentiation is difficult in real time. We face a major problem, even though the set criteria have been put. So the cold defect is seen in acute and chronic pyelonephritis. Hydronephrosis can also produce a cold defect. A cyst in a kidney can produce tumors, trauma, and infarct. All these we need to keep in mind while we are looking at the study. This is a normal DMSA scan. There is no calyx, no pelvis, smooth contour of the kidney, both the sides. I can tell you accurate sizes of this kidney. We take anterior, posterior, lateral, and oblique views of this kidney. This is a normal cortical functioning kidney. And we put a region of interest like this around the kidney to generate the function. Now, if you look at this picture here, you are seeing the cortex excellent. These are the dilated calyces. So when I take the function, I need to take only this particular areas. I'm not supposed to include this. So this is in a hydronephros kidney, the function of the cortex. In fact, many a times I'm asked a question. Once you have already diagnosed an obstructive uropathy on all your procedures, why should we be doing all these LASIK xenograms? Why not a simple DMSA scan and show the function? If the function is normal, probably you will conserve. But I think these are only debating issues, but I have not concurred on that issue over many years. Now, this is a patient where the contour of the hair is distorted, and these contours are normal, and there is absent uptake here. So this is a large scar in the upper 1/4 of the kidney. This can be quantified if you do a tomographic scan. This is another patient where the entire upper half of the kidney is absent uptake, suggesting a large scar, which can be seen here posteriorly. So the DMS scan, apart from the scars, is also used for agenesis, ectopy, horseshoe fusion, cross fusion, polycystic kidney for functional assessment, multicystic dysplastic kidney, and pseudomasses, fetal lobulations, or column of Bertini. All this, if we are confronted, we use DMS scan. This is one patient here, a classical horseshoe kidney, where you can see the horseshoe band showing functioning tissue on the DMS scan. You can see here an agenetic kidney, left side. Image is taken for a long time, only the right kidney. But this, of course, ultrasound tells you now, you don't need us. This is a classical crossed ectopia on a GHA static scan of the kidney. Finally, to come, we have an excellent study, especially All India Institute does this study day in and day out, large number, radionuclide cystogram, which in Bombay, I don't see in many of the people utilizing it. It's a very simple procedure to diagnose the reflux. Evaluation of children with recurrent UTI, follow-up after initial VCUG, assess effect of therapy, screening of siblings for reflux. Now there are two types here, direct and indirect. What we do is we take an isotope. In the direct method, a Foley's catheter is put and the isotope is put into the bladder, which is filled up, or during filling and after filling. This is a direct method. Indirect is under the ultrasound guide, we ask the patient not to void for 2-3 hours and then see that the bladder is distended under ultrasound. And under ultrasound, we inject the isotope in the distended bladder. And after we do, that is done in the sonography department or in our department. And once the isotope is in the bladder, we do a continuous imaging during voiding and also during filling if we are using a direct method. And we take a post-void image. The advantages of the technique are lower radiation, smaller amounts of reflux detectable, and you can quantify. I'll just show you one nice scan here. Isotope injected, suprapubic injection into the bladder, sequential 1-minute image. Child is passing the urine in front of the gamma camera, complete voiding, and there is no reflux. So you can, this is just a 7-minute study, 7 to 10-minute study. Whereas here, if you see, as the child is voiding, you can see the reflux of the tracer on the left kidney, increasing as the child voids, suggesting a grade 4 reflux going as high as the kidney. I can quantify this reflux using the computer algorithms here. So VU reflux demonstration, I think, is important technique and very simple, not much painful to the child. Voiding phase and post-void, we take the picture and you can demonstrate here both kidneys are having activity. Please remember there was nothing here because everything was in the bladder. So bilateral VUR. we avoided and we can quantify the entire procedure and tell you the amount of reflux, residual volume, all these details come up on that single image. Reflux nephropathy. If you have approved, and this is one of my adult patient actually, and you can see here, this kidney is contracted, considerably poor functioning cortical volume, right kidney is making up the loss. This is reflux nephropathy demonstrated on a DMSS scan. I think I'll conclude at that. Renovascular hypertension is not common in children, so I purposely avoided that entire talk. Thank you very much.
Thank you very much, sir. You've done a very exhaustive talk, and the importance of DRCG along with DTPA and DMSA. Thank you, sir. There are a few questions, sir. Will you take them now?
Yeah, please go ahead.
So I will read the questions from the chat. So there is a question regarding if the tracer is not pooled and is excreted after bladder catheterization, does it suggest bladder outlet obstruction or bladder pathology? This is regard to, of course, the DTPA scan.
Okay, can you repeat the question, please?
Do you want to ask the question? If the tracer in a DTPA is not excreted, no. If the tracer is not pooled and is excreted after bladder catheterization, does it suggest bladder outlet obstruction or bladder pathology? The question is not clear, Jyoti.
No. What you are saying that the tracer has come out of the kidney. Am I right?
Yes, sir. After
and then has gone and accumulated in the bladder.
yes. After the was showing in the pelvis, and after catheterization, it does not show it is excreted. Then should we suspect obstruction in that?
रात में यूरिन कितनी बार करते हो उठ के?
You are not audible.
Please, all the others, please mute yourself because the questions otherwise are not audible.
Hello, sir, am I audible now?
Your voice is very faint. It's very faint, your voice. Something wrong with the mic.
Sir, am I audible now?
Little better.
Yeah. Sir, so if the initial diuretic scan shows pooling, but after catheterization, the tracer...
Pooling where? Pooling at?
In the pelvis.
PUJ.
PUJ.
Okay.
And if the thing which you had shown, if the repeat scan after catheterization does not show, like the tracer gets excreted, so in that case, should we suspect a bladder outlet obstruction or any bladder pathology?
But it is difficult. I'm actually frankly telling you, I'm not getting the question clear because we were diagnosing a PUJ obstruction. Am I right?
Sir, basically, when will you catheterize the bladder? Like in case scenarios, if we order a EC scan or a DTPA scan, in which case scenarios should we tell them to catheterize and
Correct.
do that diuretic scan?
Right. At least in our department, we are not doing that. As you very rightly said just now, if you at your level are suspecting a bladder neck obstruction, right? And there is a PUJ, and we have to decide between functional and mechanical, probably one may consider a catheterization. But in the absence of any one of that, to catheterize is not my way of looking at it. I would rather go for a delayed 1 hour image which is similar to what a bladder catheterization will produce. Because bladder has no pathology. So why would bladder retain it? If bladder is retaining it due to some pathology, then catheterization is mandatory.
Thank you, sir.
Is there another question?
Yeah.
So the other question is, can we differentiate PUJ and VUJ in the graph? Will both conditions show an obstructed pattern?
PUJ and?
Vesico-ureteric junction obstruction, VUJO.
On an isotope study to demonstrate VUJ on the same side as the PUJ, much of the tracer, first the tracer has to come down the PUJ up to the VUJ, right? If the tracer is not coming down, then the question of diagnosing VUJ on that patient is very difficult. Secondly, let us assume that some tracers, 30% of the tracer has come out of the PUJ and is now held up at the VUJ level. There, we take the patient and we take the image after voiding. And if there is a persistent retention in the distal 1/4 of the ureter, we will raise a possibility of VUJ also.
Right, sir. Thank you, sir.
Right.
Ma'am, if there are no more questions, then should we end the session?
I have one question.
Yes.
That when we use DTPase, the isotope for measuring GFR,
Right.
obviously the right method to do it would be by plasma clearance and not by the application of the Gates method as far as pediatrics is concerned.
Correct.
Now, there is some amount of protein binding by DTPase.
Yes.
So in the lower ranges of GFR, would it be as accurate as chromium EDTA, which has been the standard in the Western countries?
No, we will not be accurate.
Okay.
Because the amount bound to the normally 5% of the DTP is bound to the plasma proteins. But in that setting which you mentioned, there will be significant binding. It will be fallacious data.
Okay.
So I am very strongly agreeing that in vitro method is the method for all pediatric group.
So if we use DTPA for GFR, up to what level of GFR can we say it's probably representative? Because we do not have a gold standard for GFR clinically. You know, everything is an estimate and everything has got errors.
Correct. Actually, this issue was raised by Professor Acharya when we were doing at KEM the project. So then myself, Dr. Acharya, Dr. Bharat Shah and all, we sat together and we decided why not we do in vitro estimation and DTPA GFR estimation in those select 50 patients and see the correlation. At that time, chromium EDTA was still not available with BRC. And in that study, we found close to 88% was the correlation between the DTPA and the in vitro procedures. So what overall in adult scenario, it worked. But in pediatric scenario, I continue to agree with you that probably the moment the GFR would go down by say around 25 to 30% of the normal value, we start questioning the value that is given by the procedure.
When you say in vitro methods, you're referring to what methods?
Actually, within the DTPA study which we do, there is an in vitro technique there, right? And this technique is actually, I tried to standardize it here. It is now done in AIMS, PGI, and many of the centers where we first count the radioactivity which we are injecting into the patient. And that is kept aside. And when after the injection is given, we take blood samples
Right.
from the patient at multiple time intervals and till the end of the study. And the initial activity and these blood sample activity is later on counted and the GFR is quantified.
Right. So the plasma clearance of the isotope.
That's it. So that is now continues to be done in major teaching institutions. And I tried both at Hinduja and here. I was not able to do because of various logistic issues.
Okay. And why don't we get chromium EDTA in India?
Yes, we wrote a note also, along with the transplant group also, we wrote a letter. There is some problem in the production. They had produced in between some amount, but then what they are saying is the requirement is so less. So the entire organization team has to gear up for that. So many logistic issues came. So I also got a little on the back foot. Maybe I will restart that process of discussing with the ERC.
Yeah, that would be very nice.
And with the Wadia group, we can standardize it.
Yeah.
Or KEM, any hospital.
Right.
Actually, I think at KEM hospital,
Mhm.
one of my the professor, she must be doing this in vitro technique. I'm not. I believe so. That you can check there. Shwetal, Dr. Shwetal is there.
We did a project with the BRC
Yes.
thing. One of my students did a research projects on plasma clearance of DTPA, the in vitro method,
Correct.
with two samples, two blood sampling.
Right.
And try to see the creatinine clearance, whether it anywhere matched it. And there was a huge discrepancy in what we see from creatinine clearance versus that. So this was a very long time ago.
I know. But right now, in the KEM nuclear medicine department, I think Dr. Shwetal is doing this in vitro.
Okay.
You can please check there.
I'll do that, yeah.
In Pune, we are able to do it in Inlax Budrani, where we do
correct.
all our tests. So we don't have a problem about plasma.
Efali, no?
Yes, sir.
So I think thank you for your wonderful talk. I think,
it was
some things
pleasure.
I must say before we close, that you are an excellent teacher. I mean, it may be very stupid of me to say that, but I've attended many nuclear medicine talks, and the one I remember very well and which I enjoyed greatly was a 2-week workshop which was done at Tata Hospital many years ago in the 90s, where Dr. Iski Gordon from London and Dr. Peeps from Belgium had conducted it. It was some international thing which I had attended, which was very brilliant. And we don't always get such lucid talks, which for clinicians, like we need to be kind of led by the hand, I would say, say, okay, do this. So that was really nice. I'm sure the fellows benefited a lot from it also.
It was my pleasure. Thank you.
And with ma'am's permission, I would like to also add that on behalf of the Kidney Foundation for Children, we want to really thank you for giving us permission to record this talk, Dr. Krishna, and for permission to, sort of share it with the foundation website, so that for posterity, the fellows can access it and use it when they have time. Thank you so much.
Thank you.
Okay, thank you, everyone.